All right. Hi, everyone. Is everyone able to hear me okay? Thumbs up. Okay. Perfect. Well, I love seeing all these people joining us. I'm really happy you guys can join us this evening despite all this craziness going on in the world right now. But why don't we go ahead and get started with some introductions as usual. Dr. Hirschler, would you like to start for us?
Jeremy Hirschler, I'm an addiction psychiatrist at the Lakewood Center in Cheat Lake.
Perfect. Thank you for joining. And Heather, would you like to introduce yourself?
Hi, it's Heather and Sarah from Camden.
Perfect. Thank you.
And Crystal.
And Crystal. Okay, perfect. Thanks for joining us, guys. Let's see. And Katie, do you want to introduce yourself for us?
Sure. Hey, I'm Katie Chasson Downs, calling from Morgantown, West Virginia with WVU Medicine, and Douglas Harvey may or may not be joining me at some point.
Perfect. Thank you. Everyone with Lois Vance?
I'm Lois Vance, Care Coordinator at Cabin Creek Health Systems.
Dr. Corey Wilkes, BHP.
Janelle Artist, Medical Assistant.
Catherine Darby, Medical Assistant.
Debbie Jones, Care Coordinator.
Bernard Slater, Care Manager.
Bailey Hendricks, Recovery Coach.
Perfect. Thank you, everyone, for joining. Dr. Morrison, would you like to introduce yourself for us?
Yes, Dr. Ryan Morrison, the Medical Director at Kanawha City Health Center, Cabin Creek Health Systems.
Perfect. Thank you. And Jeremy Husted, I think it is. I'm sorry if I mispronounced that.
Psychiatry fellow at WVU.
Perfect. Thank you so much for joining. And Andrew?
I'm Andrew Dango, the Program Coordinator.
Perfect. Thank you. We have a Jay Watson.
Thank you. Grafton City Hospital and the Program Coordinator for our COOP program here.
Perfect. Thank you so much. Jonathan Young, would you like to introduce yourself?
Yeah, I'm just observing today out of curiosity. I work with Garrett Moran as a program manager at WVU in the School of Public Health, and I am currently working with two grants principally. The first is the State Opioid Response Grant, and then the other one is a new CMS grant for $2.2 million to expand provider capacity in the state. So that's me.
Perfect. Thank you so much and welcome. And Tony, would you like to introduce yourself for us?
Sure. Hey, it's Tony Dikiaki, Family Practitioner School of Nursing and WVU at Chestnut Ridge in Morgantown.
Perfect. Thank you. And Sheena?
This is Sheila Kelly. I'm a psychologist with the Health Plan Managed Care Company for Medicaid and, of course, our commercial and Medicare products. And I figured, number one, I can always learn something. And number two, we like to know what people run into out in the field in terms of actually implementing MAT.
Perfect. Thank you so much. And we have Trinity Family Healthcare.
This is Hunter Keister. I'm the case manager here at Trinity.
Perfect. Thank you. And Alicia?
Hi, Alicia Heil, pharmacist with the Safe and Effective Management of Pain program.
Thank you. Megan Toscano?
Hi, this is Megan Toscano. I'm a project assistant with the SOR grant.
Perfect. Thank you. And Sheena Sayers?
Hi, I'm Sheena Sayers. I'm the program manager for the SOR MAT expansion grant here in West Virginia.
Perfect. Thank you. And we have, I think, Mega. That might be your name.
Yeah. Hi, this is Mega, project assistant for MAT expansion.
Perfect. Thank you. And Michelle Reader?
Hello.
Hi, yes, we can hear you.
So this is Danny Rader. I'm not sure how Michelle got up there, but anyway, I'm sometimes with Cabin Creek and sometimes I'm just addiction medicine interested in this ECHO project.
Perfect. Thank you so much. And I see Douglas Harvey joined us as well, so welcome. All right, so today is going to be a little bit different as it was on the schedule. So with all of this COVID-19 going on, we wanted to make some time for this session dedicated to questions related to that and maybe how it's affected anything to do with MAT. So we will start with Dr. Morrison's case. I know you had submitted 2. I didn't know if maybe there's one you wanted to start with, perhaps Dr. Morrison. I can pull up those cases for you if you'd like. We can begin with those and maybe transition into the COVID-19 questions.
Okay, let's do the one that I did from memory last time with the specifics because it's more relevant to the COVID, I think, in terms of how we're going to change our systems to try to cope with it.
Sure, absolutely. I believe it was this one. Can you see that okay?
Yes.
Okay, perfect. The floor is yours.
Great. So in my program, it's pretty widely agreed by my staff and by my my mentors at WVU that I probably do more unexpected random call-ins than probably is really necessary. I don't think there's really a set clear amount that's correct. But as a result of doing more than necessary, in part because a lot of patients actually like it to have me call them in regularly. Oddly enough, they say it helps them to stay sober. So, but a lot of them don't, and we had at least like 5 failed unexpected random call-ins in just a few month window, and that was really unusual. And every time there was all these excuses, really good excuses, and so it got into sort of, I want to be fair about, am I going to accept this excuse for this person, but not this person? And every excuse just slightly different than the last, and so, helping to figure out how we're going to make decisions with regard to calling something a failed random or a nearly failed random is important, and it's very particularly important for the care managers who I'm hoping, will be basically making these decisions without me. But whenever they ask me, how to handle it, I'm not sure yet. So that's why I have these cases. And then COVID-19 is relevant because, well, we're doing a lot less of the other things that we would normally be doing to keep people from misusing, and so so it may actually affect how we answer these questions. So, I just put a random age in person, but actually, if you get to the case presentation, it's actually 5 different mini cases of different patients that had failed randoms in this general assessment section. So let's just run one person and see what you all think. Whether we, is there different levels of failed random within the Coates protocol? And I think these cases are going to suggest that there may need to be. So the first case, a 57-year-old female, 3 years sober, running a 12-step group, very positive feedback in group, but very remote history of an anonymous tip that she was diverting from a 12-step group that she was running. But she had a very remote history of taking a few films early for increased pain. She has a lot of pain, bad back, and this occurred on a random call-in, and this is where we hear it the most. Although sometimes we get told just on a regular week, but if you're called in randomly and your wrapper count doesn't match, and you haven't been telling us that you've got pain until we call you in, it's challenging to decide if we treat that differently than if you tell you would tell us just offhand when we came to a regular visit. So we called her for a random, and she said she couldn't come in within 24 hours due to her grandson had the flu, and so this was approvable by hospital records that she brought, and she's a very depressed person, and and we've recently had to increase her dosing due to frequent requests for increased dosing, increased cravings, increased pain. I didn't, by the way, on that piece, I don't usually go above 12 on folks. That's the way the coach does it. For the most part, unless there's an extenuating circumstance or they've been on 16 from some other clinic, but I increase it to a lot lately because of battles over generic versus brand. So anyway, I think what I did. I went right through into a second case. 2 is a 41-year-old male. I really should stop on case 1, I think, and get feedback. I'm sorry, the first one is a 57-year-old female that runs 12-step groups. And she's taking her meds early. Do we treat it differently? Do we treat that as a failed random? Let's just stop there and get feedback.
Thank you for that, Dr. Morrison. Yeah, so anyone who has some feedback or comments, questions, feel free to jump in anytime. You can chat as well.
This is Wang Hong. I just want to I want to ask a question. So, how long has she been in the program? How long has she been taking the current dose?
2 or 3 years.
So, 2 to 3 years, and always the same. Basically, always the same dose. So this patient is on because I'm sorry because
the dosing thing is actually on the next patient. I messed that up.
So this patient is currently on 12 milligram.
Yes.
Okay. So she has been so this never happened to her before. So she's basically this is kind of the first time.
Yes, but I have been warning folks to tell me if you're taking your medicine early.
Okay. So have you talked to her directly? Asked her what happened and what the reason?
No. One of the care managers at Cabin Creek may remember that conversation. It wasn't long ago. That these randoms are conducted by the care management, and I haven't had a chance to talk to her about it yet.
Okay.
Did anyone chime in on that? What she said?
What was the question?
Nope.
No one spoke directly with her about taking the meds early. Okay.
Okay. So in this kind of case, if she was my patient, I usually I would ask her what happened, why she's taking a few films early, always for increased pain. I do have, I mean, frankly speaking, I have a couple of patients like this. I clearly remember one patient. I increased the dose 2 milligram after he basically told me he has been basically taking a little bit more every month, but not really. But he never used off street. He was running. He was taking more, but for a couple of days he did not have medicine, and he just basically he had to tough out. So it's kind of pretty hard for him. So I realized he really had some kind of medical issues, and asked him to talk to his medical doctor as well. And this guy did have some kind of issues with his this is kind of like a breast pain, but he's a male. Okay, so I did increase his dose. If Douglas remembers whom I'm talking about. But anyways, so I did increase his dose from 8 milligram to 10 milligram, and he's been doing really well. So I don't know in this. I mean, he has been on the medicine for a long time. Now, this guy has not used opioids or heroin for almost 10 years. So Suboxone definitely has been a very good medicine for him. And before he made it to like bi-monthly group years ago, then he relapsed on benzodiazepine. But so far now he has been doing very well. So that's one thing. And the second is if he could not come for, I mean, this never happened to him. So cannot come for random urine drug screen, and that is a different issue. So if if I'm reading this correctly, so there's two things. One is she's taking a few films early for increased pain. The second is basically she missed her random urine screen. But this is the first time she's missing. It sounds like, because she has a legitimate reason, because her grandson had a flu. So I mean, during this time, especially this coronavirus pandemic crisis. So I think this is kind of a reasonable reason. I would try to call her again back for another random urine drug screen and see what she says. And hopefully she can make it.
Yeah, that's great advice. And that's been something that's been really, I was thinking in that direction as well. But with coronavirus, I'm actually concerned about, because she's only 57, which technically is not at the age that they say is higher risk for coronavirus. But I'm wondering if I should modify my callback, like, whereas I probably would call her back within a week or two. You still think, even with coronavirus, call her and get at that. Okay. Sounds good. I don't think there's you wouldn't treat that particular one as a failed random and escalator care and go through all that. Okay.
No, I wouldn't. Yeah, thanks.
Okay. I'll go to the next case then.
Alrighty.
Scroll down just a little more, please. Oh, actually go back up. Okay. Actually, I thought we were going to go back. You know what? We'll just do this case. We're on it. So this was actually a morbidity and mortality case. This is not the random. I had two cases in, and I was going back and doing the randoms, but she understood me to be asking for the next case that was I actually had several other mini cases on the randoms, but let's go ahead and do this because I want to leave time for COVID, and I do want to talk about this morbidity and mortality case that we had. This is the first person that's ever died in my program, probably overdose related, but I don't know, after a year sober. And so this is me trying to go back and figure out what I might have done different or better to have prevented this from happening. This just doesn't happen. It's never been doing for years now. I've never had a person doing so well for so long and then lose them. And it was in the setting of a person that wanted to self-taper. But I'm going to start off as a 44-year-old white male. Well, actually, I'll start with the questions. So one of the big things is, how do I convince people that tapering is not in their best interest? Because this guy said he was going to taper, and I said, well, that's your prerogative, and I didn't really push it hard. I was saying I don't really advise it, but if that's what you want to do, then just go slow. The next thing, the question we have on this case is, this guy was a professional gambler, and he assured me that he wasn't doing it for fun or addiction. That he actually had people that paid him by the hour to coach them, but he would be the local casino gambling all the time in a very basically professional way, poker. Then the next question that we have is, well, on that question, the previous one is, well, should I have intervened? I said, well, if you think that it's not an addiction or a problem, then I'm not going to bother you about it. So I wondered if maybe that was a mistake. So the third question I have on this morbidity case is, should we have some kind of exit behavioral health intervention or ongoing behavioral health intervention after a year sober, particularly if people are wanting to taper their medicine? And then the final thoughts are, we're very concerned about people who return to use after a year sober, late return to use, I'm calling it, having deadly consequences. Because right now there's a lot of this fentanyl, and people are when they lose all those days sober, they just kind of give up on life. And so one of the things that happened in this case was he had a non-fatal overdose before committing suicide. So I feel like that might have been related with shame, although I'll never know. We were never reached out to know what was going on. But we've had several other people who did have returned to using after a year sober that really struggle to get back to a place where they were, because they just want to give up when it's like such a gut punch, when you lose that much sober time. All right, so here's the case specifics. This guy comes to us from another program. He had an argument about somebody over a tramadol that he said he took on accident, and with a prior therapist, and so it made him so upset with them he wouldn't do it with them, and he also was already he had gone back to using heroin, marijuana, oxycodone, pretty much whatever. This was back in October 2018, and it wasn't just a few weeks in, he was already sober, stayed sober like that, basically never missing a single appointment or doing anything non-compliant with the program for 329 days. At that time, he smoked THC once. He admitted it to us. Levels didn't even go that high. And it happened in the wake of him using the Narcan we gave him to save an ex-girlfriend's life who was overdosing. And then we said, well, we'll just keep going, and he stayed sober another 172 days. This was around March 5th. There was a non-fatal overdose that was not reported to me until March 16th, but before March 16th, at some point in there, he committed suicide, we're told, based on Facebook postings, and he has not returned to my clinic. So we haven't really been able to confirm the suicide. But he began self-tapering a Suboxone dose just a couple months prior to all of this, and he was using about 2/3 to 3/4. It's about 2/3 of the medicine I was giving him, and then he would bring back the meds, and then I would write, like, if he brought back if he gets 28 days of meds and he brought back 11 days worth because he was tapering himself, then I would write 17 more days, so he would get 28 more days. But then he wouldn't even use he wouldn't use as much as I wrote. But I did caution him to not not go too fast, but I think he was going a little faster than he should have, because there was a time that he brought back 11 days worth on a 28-day script. He's also a personal trainer, very handsome man. I think the rest of it I've already talked about. So I think we'll call that all I'm going to present for it, and just see what you all think in terms of the questions that I presented at the beginning.
Thank you, Dr. Morrison.
So this is Katie and Douglas. What I'd really like to do is hear from the other sites in the call to get some feedback from you all, but specifically Dr. Morrison, I'm sorry that you have had this experience. I'm sorry for you and your team when you spend time getting to know these folks, and regardless of how the loss has happened, it's always one that we feel, and so I'm so sorry.
Thank you.
Okay, yeah, this is Wan Hong again. So I want to say something about this patient, a couple of things. One is the main things, the mental health, we're talking about a comorbidity of depression, anxiety, PTSD, and other, even schizophrenia, thought disorder, any other psychiatric illness in addiction population is very common. Actually, it's 50%. We say like 50% the other way around. So we're talking about 50% of psychiatric population have comorbidity of addiction disease. So I think this patient the most likely, because we don't know, right? Because there's a rule of 7, like in suicide. They say like basically 70% of patients people who committed suicide may have mental illness. So that percentage may be higher, and and 70% of those people may just have visited a family doctor or primary care physician's office a few days before they committed suicide. So all those kind of things here. So I think you know, we don't know about this patient's mental illness. I know he probably has been receiving behavioral health treatment for his to process his ex-girlfriend's death. But otherwise, and we don't know this patient's baseline underlying psychiatric illness. So he may have severe depression, which was not really, you know, appropriately treated by a psychiatrist. So we don't know. On the other hand, it's like, you know, we have 30% or 20% of people who committed suicide because of other reasons, may not be from, you know, psychiatric reason. So we don't know anything about this. So, but we know this patient is at a high risk. Tapering off Suboxone, you know, with history of relapse, especially like long history of use and relapse, and especially we're talking about distress from girlfriend's death. I think this definitely is not a good idea. It's not a good time for him to taper off. I guess I don't know, as the MAT provider, I don't know the provider team and what else. Maybe Katie and Douglas and you know, Dr. Herschler, you guys can give you know, give more input. So here's like, as a team, what else can we do to not only treat patient's addiction problem, in the meantime, help patients, you know, we're talking about well-being and also mental illness treatment. So what other things should we do? I don't know. It's an open question, I guess. And how can we monitor? That's another thing. I know tapering off Suboxone, I would not recommend, but it's his choice. He chose to do that. I don't know what his reason was, but he chose to do that. So I don't know. Maybe it's worth like finding out why patient ask for taper off Suboxone. So we might dig a little bit more and try to figure out what else we can do and to help patient. If we feel patient is really at a risk of relapse, then we probably should, you know, try our best, do whatever we could do whatever it takes to keep patient on the medicine. Another thing is, I think it's always a team approach in this case, and I know it's very difficult for this patient. I mean, a lot of times our patients, Katie knows that, because the patient wants to be off Suboxone. There's nothing else you can do about it, right? Besides providing education and encouragement. So I work with them I always tell them, like, yes, you know, let's just work with you, and you pace yourself. You feel whatever, you know, you feel comfortable. Whenever you feel comfortable, you want to go to the next dose. I would recommend do like a little bit each time, and to make sure they can stay on it like as long as possible. I'm not sure whether that's the right approach or not, but I think the treatment team is more important than medicine itself. Right.
I guess if I was going to add one thought, you know, Suboxone or buprenorphine treats depression, and there's a good body of evidence that it shows it has antidepressant properties and anxiolytic. You know, it can help with PTSD and helps with anxiety. And so by decreasing the dose, he was probably making his psychological symptoms worse. And so that's off-label use of Suboxone, but we were kind of withdrawing his treatment of his mood and anxiety disorder.
Fascinating thing about this guy, I guess where he's a poker player, he may have been able to hide it, but I would have never imagined that he had depression at all. Like you could not see any sign of it ever when you spoke with him. And then no one on my team, I don't think, thought it either. So none of us would have predicted it, but certainly your point is well taken, Dr. Herschler, that maybe it was unmasked while we weren't even, before we were even aware, if he was rapid tapering without talking to us about it.
Was he seen every week or monthly already? How often did you see him?
Yes, he was on monthly.
So, okay, he was pretty, I mean, overall, he was pretty stable, I mean, compared with many other patients in terms of his addiction recovery.
Yes, yeah, he was one of the most stable. And one of my earlier mentors, Dr. Mary Eldred Crouch, had really encouraged me to if patients are far along and stable and they want to taper, down to 4 to 8, that's something that maybe I should even promote instead of discourage. But this has really made me averse to considering that again. To not like, I think it's almost going to be a red flag scenario where I'm thinking about activating behavioral health on people that are over a year sober if they're insisting on tapering.
I would love to hear from some of the other sites on the call. So the rest of you guys out in the state, what's your, feedback, thoughts for Dr. Morrison?
Feel free to chat us as well, and I can read the questions or comments.
Can you guys hear me now?
Yes.
It's Dawn from Minnie Hamilton. One of the things that I think I would have maybe done differently and keep in mind next time is when you know that they go through a traumatic situation like that, maybe frequently reaching out. And if you guys said that you had, I'm sorry, but reaching out via the case manager or the therapist and just checking in to see how things were going afterwards.
Thank you so much, Dawn. Were there any other comments or thoughts?
Well, I guess one other thing that I was thinking about is his gambling behavior. So, of course, gambling disorder is a DSM addictive disorder, essentially. And there's a lot of overlap between use of substances and gambling behavior. So, you wonder how good his recovery really was. And also he was in an environment where people were using substances, and so he wasn't in a good recovery environment. So, there were just some red flags about him that I was thinking about.
That's a very good point, because when you say basically he's replacing like a chemical dependence with behavior with gambling problems. So this is another kind of addiction. So that's a very good point, I think.
Whenever you all have had patients that gave you reasons to think that they should not discontinue their individual behavioral health therapy at the end of a year sober, what would have been the way that you have addressed the patient to help them to accept this idea that I'm not trying to make your life harder than the other patients, but that I'm trying to just make sure that you're safe? Is it pretty much just saying just that, or do you have, because that's something that's a bit of a challenge, when you're trying to when you're trying to give someone extra care because you're worried about them. They always feel like you're being unfair to them. I feel like it's hard to get them to accept it.
Dr. Morrison, I loved what Dr. Zhang said earlier. He framed it well in that, our role is to provide regular education, and our role is to provide a regular avenue to be thinking about these things and talking about them with us, and that we're communicating what our hope and recommendation for them is. But ultimately, at the end of the day, they get to make those decisions for their healthcare, even if they're decisions we don't agree with. I know for me, I try to catch myself if I'm telling myself in my head, well, I just need to convince them of this, or I just need to get them to do this, or I know I just need to get them to understand this. If I'm doing that, for me, it's coming from a little bit of a sort of codependent place of like, I need them to change to do what's best for me here. And that doesn't work, and that will leave me frustrated. So for me, I just have to remember like the treatment team and I have a role here to provide what we think is the best option for them, and to make that option, work the best for them and the treatment modality that we offer them. But I also have to accept that they make treatment decisions that I'm not going to agree with. And then I'm not going to shame them in the process, which, I mean, it sounds like you did a really respectful job of kind of meeting him where he was at, and he was making decisions, and you honor that those are the decisions he was making for himself.
And I agree with Katie 100% with that answer. Unfortunately, with this case, it's kind of hard to give a straightforward answer because we have to assume everything that's going on with this patient. We don't really have confirmation on what happened to the patient and what his life was like. One thing that I would encourage to continue doing is patients that have sobriety, continue letting them know, especially if they're going to taper off of their medication, that their tolerance level has decreased. So if they get into that situation of a relapse, that they no longer have the tolerance level that they used to have. So the overdose is definitely an increased possibility.
One thing that I think I may have done differently than Coates, although I'm not certain, I would like someone to clarify exactly how Coates does this. If someone gets, say, a year and a half sober, then uses THC one time and tells you about it, like this guy did, then goes right back to sober, you know, you reset their days, but when they get to the 365, or, you know, you don't hold, you basically put them into phase 3, and that is no behavioral health, or do you reset the behavioral health to monthly for a full year from there?
So if this patient's already in a monthly group, then their individual therapy requirement is they're not required to do individual therapy. If they relapse while in the monthly group and they're honest about that, we'll leave them stay in that monthly group, and we still don't require individual therapy. However, just because a patient is in a monthly group and they no longer have that requirement, that doesn't technically mean that you can't require it on a patient-to-patient basis. So if you have a patient in a monthly group and you see that they're struggling, whether it be with relapsing or depression or anxiety or anything like that, even though they're in the monthly group, you can require individual therapy for that specific patient.
And sometimes our patients just do a fantastic job of hiding it, and we're asking all the right questions in groups, and we're asking all the right questions when they're spending individual time for us, and that's the best we can do.
We've required the individual therapy in the monthly clinic out here once or twice, and it's worked really well for those folks who've needed some extra treatment. And then they've been able to actually get more into their behavioral addictions and struggles in the individual setting that they're a little more hesitant to talk about in the group setting.
Were there any other comments or questions about the 2 cases Dr. Morrison presented?
I just have a quick comment. Like Dr. Morrison, your team has been doing a wonderful job, and just by reading all these cases you present. Because I think if this person, let me assume, if this person was not receiving treatment from your clinic, he probably could have died many years ago. So I think MAT is very effective in terms of his treatment. So I don't know what else we could have done looking backwards. But I mean, I think we're doing the right thing. I mean, probably we can only learn from from the past. But unfortunately, in this case, because of limited information, we don't even know how he died. But I think that the one thing we probably could provide more education to patients is basically the tolerance. Yes, you have done that, of course, but just probably just tell them, like, whenever you taper dose, we probably just emphasize this is a risky time, and this is your tolerance definitely has changed, and make sure remember that anytime you come back, you're always welcome to come back to talk to us if you feel you need more. I think this is probably I have learned from this case. Thank you.
Thank you very much.
Thank you so much, Dr. Morrison. I'm so happy we were able to go over your 2 cases. So if anyone does have any further questions, about anything, not just the cases, feel free to always email me and I'll make sure to have them addressed and sent back to you guys. So we have received a lot of requests from people to address COVID-19, of course. And so we wanted to dedicate, the last 20 minutes or so of the session to address any questions, concerns you guys may have about that. So I just wanted to open the floor for discussion. Feel free to chime in and ask anything you may have about COVID-19 and maybe how it relates to MAT or so. The floor is everyone's. Thank you.
Yeah, on our end, we didn't have anything, prepared to give any kind of announcement or anything. We just wanted to make sure there was space open if folks had any specific questions about what they're doing for their clinics or patients.
I guess if I can bring up a couple issues that we visited here at Lakewood. So social distancing becomes an important thing to think about. And maybe the frequency of coming to the clinic should be considered differently. So those are just a couple ideas. And then how to handle people as they enter the clinic. Do you take their temperature? Do they wear a mask? So all kind of concerns that you might want to consider.
Couple of things I can share with you. So first, the initial effort we have done here is I remember Katie sent out the email. We had group discussion on what to do, and immediately, of course, to handle this emergency, we reduced the visit frequency and weekly to bi-weekly. So they originally need to be scheduled to be seen every week. So then now we decided to see them every 2 weeks. Then if they're monthly group, a bi-weekly group, then we just decided to see them once every 4 weeks. And also the monthly and bi-monthly, basically we're just calling scripts for them, because hopefully in 1 month and 2 months time and everything will be resolved. But social distancing, of course, is CDC recommendation we have to abide anyways. So we changed the room size. So basically we try to move all the groups to the largest room we could have, conference room. So we try to make sure patients each patient can be 6 feet from each other. So they can be 6 feet from each other. So hopefully with this kind of this kind of distancing can help a little bit, but I don't think it's enough anyways. So we put 2 chairs in between them, so to make sure they are 6 feet away from each other. Then I think, Katie, please correct me. So we almost canceled all the therapy groups after medical groups. So basically we decided to see them together. Is that right?
Sorry, I forgot I mute myself. Yes, we, same thing is possible that it's happened for your clinic, because our clinic plan has changed pretty much daily. Dr. Zhang was right that last week, that was the initial steps that we took, was that we just decreased everybody's frequency a level and spread the groups apart. And that has now changed in the last couple days. We had that plan in the beginning of the week, and we used that for a couple days of clinic. And then I think it was last Friday that we made the determination this week to cancel all of our coat groups just for this week. So it keeps sort of changing day by day, and there's a good chance you guys and your own clinics have been experiencing that, as every time there's sort of new news that comes down from the governor, then the hospital system or maybe your smaller agency systems make more and more changes.
So we still tell them there's a potential chance we're gonna possibly we will call them back for random urine drug screen in Peel County. So that will still continue. And also we temporarily canceled pretty much all meeting requirements, right? Mm-hmm. So we encourage them to go to online meetings. We provided like links or different kind of resources to them, right? Because every patient gets like a list of online resources, different meetings. I think individual therapy sessions continued, and also they're highly encouraged.
Yes, they have continued. They're highly encouraged. What we have changed is that we are now using we're calling patients and having telephone sessions with them and documenting them, or we're in the finishing touches of creating telehealth options, which that may be option for some of the smaller agencies, maybe not. And so actually just an hour or two before this call, the most recent update from the hospital system was that for here at Chestnut Ridge, the only sessions that will be in person are really going to be emergent sessions, so that all individual therapy sessions, provided they're not emergent, will take place either over the phone or via telemedicine.
Also, during this time, I think we not use individual therapy like sessions. We not use to hold it against the whatever, right? Because basically, because if they cannot make it because of all different kind of technical reasons, so we I think we are pretty at this time. We're not gonna do anything to punish them, as I understand, right?
Yeah, right. Understand.
We can't do that anyways. We can always reward good behavior, cannot punish the bad behavior.
Yeah.
So, but one thing I want to say is like, because I was reading, online a lot recently regarding this. So the first thing is like, actually SAMHSA has done a lot of things, and the whole in terms of policy. So because January 31st, the Secretary of the Department of Health and Human Services issues a public health emergency. So now telemedicine definitely is okay. We can use telemedicine to treat patients with addiction problem. This is a good thing. So so I'm pretty sure regulations will change and the reimbursement policy will change. Medicaid and Medicare will have already started acting on this, right? So I think this is definitely, I think nobody needs to worry about that. Another thing is, I think SAMHSA also said under the emergency, under medical, let me read this, let me find it. So under medical emergency exception, providers make their own determinations whether a bona fide medical emergency exists for purposes of providing needed treatment to patients. So in other words, we can treat patient in like, as long as we feel this is kind of emergent case. So we can pretty much improvise our own ways to help patients. I think this is very important. So we should use, also SAMHSA clearly said, outpatient treatment options be used to the greatest extent possible. So whenever we can use outpatient and whenever we can use IOP, intensive outpatient, of course, does not really apply to this group, but we should use that instead of hospitalizing patient or put them in like rehab programs. So remember, we don't need to, at this time, the Reinhardt Act has been basically suspended. So basically we lifted already. So we do not really need to see patient in person for the initial evaluation now. So I think this is a good news to us. So we can, if somebody wants to establish treatment with us remotely, and also HIPAA has been waived. So we do not really need patient to sign a paper consent in order to engage in treatment at this time, as long as the patient can, I think as long as, if somebody can correct me, as long as the patient can consent remotely, and so we should be able to start treatment. And also that basically we can just establish care for patient like, remotely now. So through telemedicine. So which I think this is a great thing. This is, I hope more and more patients can establish treatments with us. Yeah.
I'd like to ask about the HIPAA changes. If they're going to be carried over to CFR 42, I'm a little concerned about having a group medical management visit via telehealth, unless CFR 42 is relaxed for a national emergency the way that HIPAA has been.
Yeah, it's waived right now. The laws for the HIPAA has been waived during this crisis.
Are you referring to CFR 42 when you say
yeah.
that? Okay.
Yes, they have been waived. I do have a question. We are still trying to determine what codes to bill for telehealth, for telephone. Do you guys know yet what they are?
I used 99446 for 5 to 10 minutes. I think the 44. If you double check, there will be 99447 and 448. So that's for telemedicine encounters. And the department sent us an email with a list of like 99441, but I could not find those codes in our billing like list. So what I used this afternoon was 99446. So that was only like a 5 to 10 minutes like a visit. So the problem is like basically for group visit is so how now we cannot have patients. We cannot have patients sit in the same room as a real group. So patients have to, each patient has to access through their own client side, or maybe a cell phone, smartphone, or maybe a computer. So basically patients will stay wherever it is. So it could be their house, it could be their workplace. So you're seeing a group of patients basically scattered everywhere. So I don't know how, frankly speaking, this is a new way to deliver group therapy, because before so far the most commonly practiced group therapy that's through telemedicine was like a patient's really still sitting in a group in a place, in a local mental health facility or clinic. Then the clinician or therapist or medical provider, talking about a Suboxone provider, can see patients from a remote office. So that's the most common way of delivery. So I don't know now everything has changed, so it's hard to say.
If I could just give a plug for self-care right now. You guys as healthcare providers are working absolutely overtime right now. We have all of our normal workload, caseload that we're taking care of, and then on top of that, try to deal with the anxieties of our patients, the anxieties of our coworkers, the anxiety out in the community. So to make sure that you're taking care of yourself right now and really putting some extra TLC on the table. Speaking of self-care, I'd like to point out, Tony texted me and asked me if I was drinking a beer on the call, and I swear it's just a Perrier water. I just felt like I needed to say that.
So is the game plan as of today? Of course, it'll change tomorrow for WVU Morgantown. Is going to be all telehealth, but otherwise group medical management with combined group behavioral health on a single Zoom call?
No, that is not our plan as of yet. We do not have anything, we do not have groups set up for tele. So for this week, we are not having groups. If that changes, if we figure out a way to make that happen, we will be happy to share that with you guys. But as of this moment, we don't have tele set up for group just yet.
Yeah, well, the code I used, basically the billing code I used basically was individual. So I saw patient remotely through FaceTime. so yeah.
Oh wow. That's our plan too. Our management's trying to set up Zoom through us, so everything will be done through Zoom. This week we also canceled our groups. We're going to see everybody individually this week, and then hopefully by next week we'll be able to do it through Zoom and have them, all come to the same time by tele.
And in terms of urine drug screens, where we're going to be doing it tele, or we were going to be just going with less urine drug screens, I presume? Is there a decision by Morgantown on that at all yet?
I am not aware of a decision on that. Dr. Zhang, have you heard?
Nope. Dr. Hirschler, your side, do you have any update?
I mean, I think it's fluid, so I don't know what the final result will be about how we approach things, but we're changing every day, so I don't know how we'll handle drug screens. It's a good question.
I know for us, I think the plan is to increase random call-ins to make up for the fact that we're not having the regular routine clinic screens.
But personally, I think we should have one a hotline to handle all different kind of urgent cases. Is that something we're considering, Douglas?
Is that about a hotline?
I mean, that definitely is a possibility. I don't think we have anything set up right now. We're, like Katie said, we're taking it hour by hour. So right now we have a game plan kind of in place, but in an hour, that game plan will probably have to change.
Were there any other comments or questions concerning COVID-19 and your clinic specifically? Thank you all so much for your input. I really appreciate it. I did want to also say that this Thursday at our hepatitis C echo session, we are actually dedicating that whole session to discussions revolving around COVID-19 and bring any comments or questions there as well. And Dr. Hodder, who is an infectious disease doctor, is going to be providing a brief didactic on that as well. So feel free to join that session if you do have any further questions. If you didn't receive an email already with the Zoom link to attend that, just shoot me an email. I'll make sure you have all the information for that as well. So I did want to ask everyone before we do part our ways, we have about 5 minutes. If there are any other comments or questions going back to the case or anything, feel free to chat it as well if you'd like. All right, well, thank you all so much. Our next session is on April 13th, and Dr. Zhang is providing our didactic on diagnosing case severity. So keep an eye out for that, and everyone stay safe. Thank you all so much for the great discussions. Thank you, Dr. Morrison, for the cases. We really appreciate you guys. Thank you, guys.
Thank you.
Thank you.